Well, good afternoon, ladies and gentlemen. Thank you for attending the SHARP webinar series. We'll be talking about peripheral vascular disease this afternoon. Just a few housekeeping rules before I start. As usual, if you could turn your cameras off and mute your microphones. At the end, there will be an opportunity to ask questions when you can turn your camera on, unmute your microphone, raise your hand, and it'll be great to have some discussion around what Professor Belch has to present. So Professor Jill Belch needs no introduction to most of us here, but for those of you perhaps who have not or not in Tayside, she's Professor of Vascular Medicine. She's also the immediate past president of the European Society of Vascular Medicine. She is a distinguished founder, fellow of the Academy of Medical Sciences, and member of the Royal Society of Edinburgh, and was awarded an OBE in 2016 for services to medicine. And in 2019, she was also voted the Saltire Outstanding Woman of the Year. So she clearly many accomplishments, but her main areas of specialty has been in peripheral arterial disease and vascular medicine. And also, she did quite a lot of work in rheumatic diseases as well. She was a chief investigator of the Poppedard study, as many of you will know. So it is a great honor to have Professor Belch to speak to us today on updates and current cardiovascular risk in peripheral arterial disease. So Jill, over to you.
Great, thank you very much for that introduction. I sort of struggled to recognize myself after the panic I've had the last 5 minutes as my Teams not working. I'd like to just double check that I have actually shared my screen and that you can see the PowerPoint presentation. Jacob, can you see it?
Yes, we can, Jill. Thank you.
Lovely, thank you. Well, thank you very much indeed for inviting me to come and talk about cardiovascular risk in peripheral arterial disease. Before we start, I'd like just to remind you that SHARP is a charity and it's entirely free to join. You can go onto the webpage or send an email if you would like to join us. Now, these are my disclosures, and here's the first slide. Just briefly to go over a couple of things before I start on risk, I'm going to talk about atherosclerotic peripheral arterial disease, not any other type. And as I'm sure you know, there are two forms, critical limb ischemia and intermittent claudication. And these are pictures of critical limb ischemia. Here we have acute limb ischemia and the white leg and either the plaque is ruptured or the embolus has come down and cut off the blood supply. Clinical emergency has to be operated on immediately. And here we have critical limb ischemia, which is also an emergency, but 2 or 3 days can be put aside to treat it. And gradually what happens is that the toes just die right up through the foot and, of course, into the rest of the leg if you don't treat it. Now, luckily, this is a very small proportion of our PAD patients. Only 5 to 15% will ever get to this stage. And of course, the majority have intermittent claudication. Now, intermittent claudication, I always think of intermittent claudication as actually being angina of the legs. It's identical, of course, pain going upstairs, going up hills. And I'd like you just to hold in your mind how you treat angina patients compared to how you treat peripheral arterial disease patients, and if there is any real difference, considering that the pathology is very similar. Like all atherosclerotic disease, it is a disease of the elderly, probably 5 to 10 years later than coronary disease, and that's probably related to the fact that the vessels are bigger and they just take longer to silt up. And about 10% will have it when they're in their 70s. But if you have diabetes or if you are a smoker or other risk factors, then your prevalence will be as high as 22%. So it's actually, it's very common. And it's estimated that within the EU and the UK, there's about 27 million adults with peripheral arterial disease. And as our population ages, this will go up to 36 million. So they are going to be quite a clinical burden for you in primary care. Now, we tell everyone to measure peripheral pulses, And I don't know how easy you find it to do, but we know that if you don't do it all the time, it's not actually easy at all. And there are other confounding things like you can feel your own pulse, the patients often have edematous legs. And of course, the anatomy can vary in 10% of the folks, so you just don't feel them. And what we recommend, of course, is the ankle breaker pressure index, where the arm blood pressure is divided into the ankle pressure, and you get a ratio. And here's our normal of 1 to 1.3. And if it's lower than that, a suspicion of peripheral arterial disease. And at 0.9, we make the diagnosis because we know with a 90% sensitivity that there is a 50% stenosis of one of the major vessels at levels below 0.9. Now, some people can do it themselves. Other people will get their community nurses to do it because, of course, they have to do it before they bandage for venous ulcers, and others will send it to vascular laboratories. But this is by far the best way to diagnose peripheral arterial disease. And here's what happens to your leg when you have peripheral arterial disease. 3/4 of your patients are going to be fine. Only a quarter deteriorate, and only 2% go to amputation. And because of this benign outlook in the leg, previously it was thought that peripheral arterial disease was really a benign disease and not much attention was paid to it. And we know that there are 100 patients with claudication having the outcome in the leg, but there's also 100 patients with claudication who don't come to you because they think it's just their back, they think they're getting older, they possibly don't walk far enough to get claudication. And then there's also the 100 patients whose ABI is low, but they don't have any symptoms. Perhaps they have a peripheral neuropathy with diabetes, or again, they don't walk far enough, or they're inhibited by chest disease or something like that. So in fact, we do have more patients than we know that have peripheral arterial disease. And here's the issue. The issue is that these patients have systemic events, and there's 10 to 20 of these events every 5 years. And you will see that there's 25 to 30 deaths, the majority of which are cardiovascular. So our 27 million becomes 81 million people with peripheral arterial disease, and all of them have this risk of cardiovascular disease. Now, this is Michael Creaky's work, the San Diego study, and you'll see it was done between 78 and 1990. And this is the 10-year survival. And you can see at 5 years, 25% of folk have died, no matter whether it's asymptomatic, intermittent claudication, or critical limb ischemia. And by 10 years, about 50% of these first two groups have died, and nearly 75% of those with CLI. And so I can hear you say, well, that was the same with heart disease in those days. But if you look at the more modern data, and here we are 30 years on, 2006, 2018, the same figures are shown. At 5 years, you have 25% mortality, and at 10 years, you have 50% mortality. So we're not doing terribly well with these patients. And here's even more recent data looking at critical limb ischemia. And you remember in the 1970s, 80s, Creaky's data showed 75% of folk dying at 10 years. And indeed, it's entirely unchanged just a couple of years ago. And in terms of asymptomatic disease, studies done in 2021, and you can see again, if your ABI is normal, you're fine, but as your ABI falls, your risk goes up, and your mortality is again 25% at 5 years. So if you look at this compared to common cancers, you might be surprised to see actually how bad it is in comparison. And if you were to say to a patient, would you rather have breast cancer or prostate cancer or indeed Hodgkin's lymphoma, or would you like some pain in your legs as you walk? I think the vast majority of people would actually choose pain in their legs, and they would be wrong because in fact, it equates exactly to Duke stage B carcinoma of colon. And if you compare that to coronary disease, and I'm afraid this is 6-year data because there's no 5-year data, recent 5-year data available, you will see that in PAD you have almost double the mortality. And I wonder if when a peripheral arterial disease patient comes to you, if you say, oh gosh, this patient has a much higher chance of dying than a patient with angina or myocardial infarction. And if you actually then put in critical limb ischemia, the mortality is very similar to that of lung cancer. It's actually a terminal diagnosis, and we really need to act very quickly. Unsurprisingly, because of it being atherosclerotic, the vast majority of deaths are through coronary disease or stroke. And it's often part of polyvascular disease, where you can have cerebrovascular disease or coronary disease as well, or indeed all three of them. So what are the risk factors? Well, these are our old friends, and you'll recognize them, of course. They're not any different. Slightly more risk of PAD with diabetes and smoking, but still very similar to coronary disease. Now, I'm not going to go through each of these because clearly I'm sure you know how to manage risk. And what I'd like to do is just focus on some of the newer aspects that are around these days. First of all, male sex. We always associate PAD with male sex, but in fact, now that we're part of a multicultural society, it's really important to note that if you are a Black female, you have exactly the same prevalence of peripheral arterial disease as white males and Black males. And it's only the white females where it's less frequent. And even then, that is increasing as cigarette smoking increases in the female population. Here's diabetes. And again, I'm not going to go into how to manage diabetes. I'm sure you know how to do this, but I just thought it was worthwhile pointing out how badly these patients do. The data are from 85, they're also from 2006, and now from 2022, that 71% of amputations will occur in patients with diabetes. And in fact, the 2022 data suggests that 80% of people who have amputation have diabetes. So it's really important that with your skills, you are absolutely tough on diabetes in patients who have PAD. And in fact, if you look at your death rate, again, at 10 years with your PAD coming in at 50%, if you have intermittent claudication and diabetes, your death rate becomes that of critical limb ischemia, and that is 75% death rate in 5 years. So diabetes is a really bad news. And as I say, I'm not going to talk about management. I'm sure you know how to do it. But what I'm going to stress is that we haven't improved our outcome, and we really need to be careful of these patients and make sure their legs and feet are checked regularly. Smoking cessation, very commonly associated with PAD. And in fact, 99% of people are smokers or ex-smoker. And of course, you'll be familiar with this data showing that if you give up smoking, you'll maintain your claudication. But if you keep going, you'll end up with critical limb ischemia. You're much more liable to clot off your vascular grafts. And again, I know that in primary care, a lot of your workload is managing smoking cessation. And a lot of my patients come to me and they say, I really am too embarrassed to go back to my GP because I failed with whatever treatment they got. And so really, rather than go over the treatment, which I'm sure you know of smoking cessation, I just want to make a plea for these elderly patients. Here's some of the stuff that we were exposed to in the 60s and the 70s. And it's absolutely stunning when you look at the adverts that were in all the newspapers in those days. Here's your dentist recommending smoking. Here's your Chesterfield showing that scientific evidence is that it's good for you. Here's Lucky's, less irritating to your throat. And of course, the problem that we still have today, and that is the subtle advertising, excuse me, that it's going to help with weight loss. And I remember Marlboro Slims being very tempted as a way to lose weight loss. So my message today on smoking is not how to stop it, because you know what to say to your patients, but actually to forgive them a wee bit and to make it easier for them to come back if they fail with their initial strategy. So moving on really to the main thrust of the chat, And that is our current areas of debate in risk factor management. And those two areas, lipid lowering and the management of thrombotic risk. And I want to run through the evidence, hopefully setting the scene for discussion later. Here is the statin study, heart protection study. And what you will recollect is about 20,000 patients, and the vast majority were enrolled because they had a cholesterol above 3.5. But there was quite a number with peripheral arterial disease, over 6,000, 6,700, etc. And what you can see is that patients with peripheral arterial disease did as well as those with stroke and with diabetes and with heart attack, in that statins reduced your cardiovascular events. And this study came out in 2002, and we all started to prescribe statins for our patients. But what is not quite so well recognized is that we give statins to peripheral arterial disease patients not just to stop heart attack and stroke, but actually to stop progression in the leg. And this is very important because a lot of my patients will come to me and say, well, they told me about the statin, but I don't have heart disease at the moment, and I don't like taking so many tablets. And it's really important that if people come to you with peripheral arterial disease, that you stress the statin will also treat the peripheral arterial disease. And here you can see adverse limb outcomes such as amputation, acute limb ischemia, critical limb ischemia, and you can see that those on a statin did much better than those that didn't take a statin in this REACH registry of over 8,000 people. And here's another study. Again, it's observational, but very large numbers. And they looked at amputation as well as all-cause mortality. And as you would expect, those with no statin compared to those with high had much less 5-year mortality, but they also had much less amputation. So again, we are actually treating the peripheral arterial disease as well as giving them secondary prevention. And these two meta-analyses of 3 studies each. This is amputation-free survival, so it combines mortality and amputation. And here you've got amputation by itself. And in both, you can see that the events are decreased by statin. So statins are actually good for the leg as well as the heart. Early on, before we started to give statins to everybody, we looked at whether statins actually help the intermittent claudication symptoms. And this is one study by Moeller, but there's 4 or 5, and all of them show the same thing. And that is when you give a statin, you actually increase your maximum walking distance and your pain-free walking distance. And so not only are you helping to prevent amputation, but you actually are possibly going to help the patient's pain. And this really does affect compliance when you chat this through with your patients. And here's graft patency, primary and secondary. And you can see again, those on a statin doing much better. Secondary, it has required to go back to surgery because it has occluded, and then the statin has helped. I'm never quite sure if this study's a bit unethical because it was done in 2013. However, it certainly proves the point that after your graft, you do much better on a statin. So again, something useful to tell your patients to maintain compliance. And compliance is really important in peripheral arterial disease. Here you can see your patients who maintain a high dose of statin. After the Daily Mail articles, patients began to either reduce their dosage or they stopped it. And what you can see here is your survival falls off as you stop your statin in peripheral arterial disease patients. So compliance, getting your patients to take the statin is vitally important. And I believe telling them how it helps the leg is really important. The other thing is in the elderly with PAD, I know we're all trying to avoid polypharmacy, but please don't stop your statin when people get older than 75. Here's what happens. Here's your mortality as people continue on statin. Yes, of course, they are old, they will die. But here's the rate of death. If you stop your statin, you almost go back to as if you've never had it before. So actually compliance is vitally important for our PAD patients. And a lot of our recent guidelines, of course, recommend that not only do we have it for the prevention of cardiovascular events, but that we also reduce limb loss with this treatment. And of course, there is a target given to the vast majority of the international and European guidelines, and that is to take your LDL down to 1.4 or to reduce it by 50%. And if you can't do that with the statin alone, then on very little evidence, it is suggested that you add in ezetimibe. And as you can see, it's yellow here. There's very little evidence, but I think clinically you will have seen patients who haven't got to target, but you add ezetimibe in and they do get to target. However, not all our PAD patients will get down to the target of 1.4 or the 50% drop. So what is next? Well, it's the PCSK9 inhibitors. And this is the Fourier study with evolocumab. And what you'll see is that actually the patients with peripheral arterial disease benefited most compared to actually patients with coronary disease. And you can see they had a relative risk reduction quite convincing with the number needed to treat after 900 days of 29. Now, of course, this is given by injection. And of course, it's limited to people who are not reaching target. But please remember your PAD patients, because these folk were already on the maximum tolerated statin, and they still had this decrease in MI stroke and cardiovascular death. And additionally, if this study is showing that your maximum walking time and your pain-free walking time significantly increase with evolocumab as well. So you can persuade your patients that these injections are worthwhile, not just to protect their heart and brain, but also for their legs. And this has led to the recent recommendation from the European Atherosclerosis Society and the European Society of Vascular Medicine that not only do you go down to these levels and add ezetimibe, but if you don't get to target, then you should introduce a PCSK9 inhibitor. So, in summary, statins will decrease your events, as we know, and that's including amputation, and may increase your walking ability. And we all use statins. I guess the question I have to you is, do you recheck and make sure that you are treating to target? And if you don't do that, I think that's wrong, and it'd be good to discuss it. Because if I had peripheral arterial disease, I would want my LDL to be less than 1.4. And I would expect it to be checked. And if I didn't reach target on the statin and ezetimibe, I would want a PCSK9 inhibitor. So that's one area I'd like to discuss and see what you feel about it. So of course, if we go back now to our risk, we have platelet aggregation and thrombosis. So let's look at what's new in that area. All the aspirin therapy started really with the antithrombotic trialist collaboration, and you can see that an antiplatelet treatment is better in peripheral arterial disease, a goodly number again, as it is with coronary disease, etc., etc. And this is what's led people to use antiplatelet treatments in peripheral arterial disease. But interestingly, these studies are not of aspirin shown here, but the vast majority of the studies in peripheral arterial disease were in ticlopidine, which is, of course, the mother of clopidogrel. And there really is no evidence for the use of aspirin in peripheral arterial disease, such that a number of European countries, such as Germany and Austria, never licensed aspirin for use in peripheral arterial disease. And here's the Popedad study looking at the end points of the usual cardiovascular death, stroke, MI, and amputation. And what you'll see is whether you give aspirin or not, the major adverse cardiac events are unchanged, as is cardiac death after 8 years. No benefit from aspirin in patients with PAD and diabetes. And at this, just about a year later, Jerry Fowlkes published his AAA study showing exactly the same, no benefit in aspirin. And a year after that, there was a huge Japanese study that also showed no benefit from aspirin. And there have been a number of studies since then, and this is one just out last week, and again, showing no benefit in PAD from aspirin. So what do? Well, this is the Capri study. And you'll remember that when it came out, people sort of mocked it because there was this very small overall relative risk reduction in your endpoints here. And if you look at the patients that were enrolled, the vast majority of this benefit was in your peripheral arterial disease patients with some in stroke. And in fact, very little benefit for those with myocardial infarction. And in fact, these data were never published for years because Bayer didn't want the drug not used in myocardial infarction. But most of the benefit in the Capri study went to patients with peripheral arterial disease. And because of this, quite a number of guidelines will say no evidence for aspirin. Capri study, subgroup analysis, yes, but it's a goodly number, 6,500 patients. And so clopidogrel is what we use to treat our peripheral arterial disease patients. And of course, that means that you often get away without prescribing your omeprazole type drugs when you're giving aspirin. So there's some benefits for your polypharmacy. So we were all happily giving statins, treating with clopidogrel, and then along came COMPASS. COMPASS was a study in coronary disease and peripheral arterial disease, where they gave rivaroxaban and aspirin, rivaroxaban alone, and compared it to aspirin. And here are the results. And what you can see in terms of your primary endpoint is far less with the combination of rivaroxaban and aspirin. Interestingly, in the subgroup of peripheral arterial disease, the rivaroxaban alone just failed to make significance by 0.01, and that possibly reflects the fact that aspirin really doesn't do anything in these patients. And if you look not just at your major adverse cardiac events, but at your major adverse limb events or major amputation, what you can see here is that rivaroxaban is actually better than aspirin or clopidogrel alone in terms of peripheral arterial disease, symptomatic PAD, and lower extremities. Now, I have to apologize. Something has happened to that slide, and the axis is moved. It's actually, the axis is here, so it's actually very much more convincing than you're seeing here. So apologies for that. I don't understand why that happened. But as you know, your axis is at 1, and that line should have come down at 1, but it shifted. So in fact, very convincing benefit in carotid disease and in peripheral arterial disease and in symptomatic PAD. And then along came the Voyager trial, a very similar trial, but this time the patients were going for revascularization, and it was only peripheral arterial disease patients, only 6,500, and they were given rivaroxaban, and the patients, the people looking after, the doctors looking after the patients could decide whether to give aspirin or clopidogrel, and they were randomized, as you can see here. And here's your principal efficacy endpoints, limb ischemia, amputation, MI, stroke, cardiovascular death, the usual ones, with bleeding as your safety outcome. And here's the results. And as you can see, a fall in the incidence of events. And they worked out that your number needed to treat at 6 months, 65, number needed to treat 12 months, 50, and by the time you got out to 3 years, the number needed to treat to stop one event was round about 40. And that was your primary endpoint. And if you compare the events stopped, these are the events reduced over time, to the bleeding, you can see that you get your little peak of bleeding at the beginning, which is usual, and then there's very little increase thereafter, so relatively safe. And this led the European Atherosclerosis Society and the European Society of Vascular Medicine in their statement to say that the antiplatelet therapy, antithrombotic therapy should be either clopidogrel or the combination of aspirin and rivaroxaban. And so I would say that we see that it decreases events, this combination. And if I had peripheral arterial disease and a bypass operation and a low bleeding risk, I think I would want rivaroxaban and aspirin. The evidence is convincing. And I'd like to know if this is what you think too, and is this, if is what you actually do. Moving on now to the ACE inhibitors. And again, I'm not going to talk about how to manage blood pressure. I'm sure you're absolutely skillful in that, and there's no need for me to do this. But one of the issues is I often get people coming up to me with established peripheral arterial disease who do not take an ACE inhibitor. And the rationale for that, for taking it, comes from the HOPE study. And here you can see patients on placebo, patients on ramipril, and obviously there was a decrease in stroke, cardiovascular death, and MI. And if you break this down, what's not recognized is that actually patients with PAD did much better than the patients with coronary disease alone, although all of them moved from one, showing that ramipril ACE inhibitor was of benefit. And somehow it's caught on to the coronary disease patients, but I'm not sure it's caught on in peripheral arterial disease, as I get a lot of patients referred up to me who are not actually on ACE inhibitors. So again, if I had PAD, I would want an ACE inhibitor, a statin, and clopidogrel. But of course, I'm old and you're worried about polypharmacy. But in fact, I think if you look at the evidence, these are not the ones to stop. And I'd like to discuss that. No matter what, we're not doing well because the event rate from the 70s and 80s is still the same in the 2000s and the 2010s. And therefore, we really need to do better in managing our patients. And we do know that the more risk factors you manage, the better your outcome. Here's all risk factors managed in white, nothing cardiovascular deaths, no non-fatal MI. Here's your stroke, and here's death, MI, and stroke composite. And you can see quite a distinct fall when you manage them all. And again, this is 80,000 patients in the REACH registry. Another study here showing exactly the same. The more risk factors you manage, the less you die. So here you've got hardly 4 to 6 risk factors not managed, yet you're dying. And here you have 0 to 1, and you die less frequently. So we do need to manage all our risk factors. Now, these are data from 2007. And what it really shows is that we're focused more on coronary disease than we are on PAD. So in terms of statin, only 27%, remember 2007 is well past the heart protection study, only 27% got statin compared to 67% of your coronary disease. ACE inhibitors, very similar, and antiplatelet agents, very similar again. And over the years, I've seen these studies repeated again and again, and it's very strange that a lot of folk will repeat these studies, but actually things don't change. I am pleased to say that a study that came out 3 weeks ago is the first study that I actually am beginning to see a movement towards better management. And this is statin here, aspirin, clopidogrel, and an ACE inhibitor or an ARB. Now, this is altogether PAD and coronary disease, and you can see that actually we're not managing to get everybody onto statin, but most people. But when you look at coronary disease, more people are getting statin than in peripheral arterial disease. And the same is so for antiplatelet treatment. Again, here's your coronary patients, 90% of men are getting a treatment compared to 81% of men with peripheral arterial disease, and the same for women. And again, here we have ACE inhibitors, and very much fewer patients with peripheral arterial disease get an ACE inhibitor than those with coronary disease. And there's also a very interesting sex difference there, which we can also discuss. And the importance of managing risk is not just for the leg or to secondary prevention, but once you've had your myocardial infarction, actually your ABI predicts if you then go on to die. So the lower your ankle breaker index, the more likely you are to get a further cardiac event. If you have peripheral arterial disease, you're more likely to have a complication of a periprocedural complication of CABG or PTCA. And here you can see mortality after myocardial infarction treated with PCI. And again, if you have peripheral arterial disease, your chance of dying is much higher. So it's a pretty nasty thing to have on top of your coronary disease. Now, the final risk factor I'd like to talk about is air pollution, if I may. And this is a study to look at hospital admissions dependent on what the pollution is like. And this was carried out in Tayside, and the study was over 18 years. Patients were diagnosed as having acute limb ischemia if they required urgent intervention or amputation over 3 days. And the pollution measured was the nitrogen gases, nitric oxide, NO and NO2, which together form the NOxes, particulate matter 10, and to a certain extent PM2.5, but Perth didn't start to measure that until 15 years ago, so less data for that. And here you can see the NOx, the nitric gases in Perth and in Dundee over the 18 years. And what you can see is if you add your NOx, your NO and your NO2 together, your level should be under 100. And here you can see the levels peaking every winter time as they do, and often even in the summer being above the legal limit. Same for Dundee. And these are hospital admissions. Here's your hospital admission when pollution is, on days when pollution is within legal limits. And here's your second quartile, your third and fourth. And as you can see, as your NOx goes up, so your admission levels go up. And similarly with particulate matter, they're not quite so convincing as PM10 going up when you come in. Now, it could be that the NOx is making you more thrombotic, or it could be precipitating cardiac arrhythmia and they're throwing off an embolus, but no matter what, these patients are being admitted to excess. And here we have it when it's low and when it's legal. And as you go up the quartiles, you can see the increase in admission numbers. And here you have over 120 extra admissions a year because of high air pollution. And you may say, well, that's not a lot, but actually it is. That's 12 a month patients coming in with acute limb ischemia requiring operations. So think of the cost, not just to the patient, but to the community in terms of NHS costs for surgery. 12 a month, that's a lot of critical limb ischemia. So air pollution is linked to lots of other diseases, and it is now a health and legislative priority. And through this presentation, I would like to remind you of the Lancet's document on air pollution, saying that when our patients are exposed to such a clear and avoidable cause of death, illness and disability, it is our duty as doctors to speak out. And I know that a lot of primary care physicians in London are now noting if their patients are coming from high pollution areas. And I think really it behooves us all to be aware of air pollution as a risk factor for very many diseases and to speak out and act against it when we can. What about erectile dysfunction as a risk factor for peripheral arterial disease? Here's a statement from Professor Jackson, expert in erectile dysfunction. A man with erectile dysfunction and no cardiac symptoms is a cardiac patient until proven otherwise. And the data, very convincing data, show that men present with erectile dysfunction on average 39 months before developing acute chest pain or their peripheral arterial disease. So it's a really good warning sign. It's common, estimate 50% of men over 65, and it's an independent risk factor for cardiovascular disease equivalent to a moderate smoker. Now, you probably all know that, but I guess the question is, do you ask your patients if they have erectile dysfunction? And here's the gold standard management from the British Society for Sexual Medicine that keep saying to us, there can be no longer an excuse for avoiding discussions about sexual activity due to embarrassment in our patients with coronary disease, stroke disease, and peripheral arterial disease. So another question for discussion, do we all do this? So in conclusion, ladies and gentlemen, do we manage lipids well? Do we give appropriate antithrombotics? What about an ACE inhibitor? Do we give that to peripheral arterial disease patients? Do you not document where your patients live? Do you know? And also, do you know if your patients have erectile dysfunction? And I'd really be interested to hear your thoughts on these points and look forward to discussing them with you. Thank you.
Thank you very much, Jill, for that very clear and thorough tour de force of peripheral arterial disease. And I'll just open up to questions from the audience. Feel free to turn your camera on and speak or raise your hand or even just type questions in the chat if you have any for Professor Belch. Jill, maybe I'll just start off by asking you about the statin impact in peripheral vascular disease, peripheral arterial disease. It's very clear from what you presented that it's effective, but is it because of its lipid lowering effect, do you think, or is there something else in terms of plaque stabilization or some of the other pleiotropic effects? What are your thoughts on that?
Yeah, I mean, I was pretty amazed at that data on 75-year-olds showing that how quickly they fell back to actually never having had a statin before.
Yeah.
Now, we've actually done some work looking at reperfusion injury. And of course, as you walk, you stop, your blood vessels can't get the blood through, and then you stop again and you're reperfused with free radicals. And there is no doubt that statins will scavenge your free radicals. It does, of course, stabilize plaque. What we don't know is if you stop a statin, do your plaques become unstable again? Do you remove the fibrous coat or whatever? But I do think that there is something more than lipid lowering going on because of the rapidity of death that comes back when you actually stop your statin.
Yeah, thank you. I'm still waiting to see if people have questions. No one's raised their hands. I think you've stunned them into
Totally, I have.
silence. Uh, but
I mean,
but maybe I will just ask one other question whilst we're waiting for people to think about questions to ask. And that's really, you spoke very clearly about the link between coronary artery disease and peripheral arterial disease. You talked about erectile dysfunction and peripheral arterial disease. What about cerebrovascular disease? Because of course, that's another huge area where we talk about atherosclerosis of a crucial blood supply conduit in the carotid arteries.
yeah.
What is the data at the moment? Is the relationship equally strong? Is it stronger in cerebrovascular disease?
Well, it's very interesting because I showed the slide showing that peripheral arterial disease is often a polyvascular disease. And the reason for that is that your blood vessels going to your leg are actually quite big. And so before you actually get symptoms, you've actually silted up your arteries quite a lot. And we do know from coronary angiogram studies, slightly unethical, that anybody with peripheral arterial disease has coronary disease, and that from Doppler ultrasound, that you're very likely to have plaque as well. The interesting thing is that if you look at the PCSK9 inhibitor studies, and if you look at the clopidogrel studies and the rivaroxaban studies, carotid disease and peripheral arterial disease actually seem to do better with treatment than coronary disease. And whether that's because coronary disease, when it happens, actually damages the heart, and so that you've got a chance of going into end-stage heart failure, whereas with carotid disease, yes, you have strokes, but they are often mini strokes that you can live through. And with peripheral arterial disease, of course, it's just the muscles of the legs. And so once you sort it with therapy, your actually mortality is less. But that's an interesting question. And it's now being confused in the literature because big pharma is calling carotid disease peripheral arterial disease. And so, for example, the COMPASS study, the patients with peripheral arterial disease have a mixture of carotid disease and peripheral arterial disease. So you've got to actually be very careful when reading the papers. But in terms of risk factor management, it's very similar. I
Thank
mean,
you, Jill. We've got a question here, Jill, from Heather, who asks, I think I know the answer to this, but I'll let you. Can I ask if there's any advice about stopping or not starting statins in the elderly, i.e., over the age of 80 to reduce polypharmacy?
Yeah. To be honest with you, the early studies didn't include old people or indeed women, as is usual in the sort of 80s and 90s. But now a lot of medicine for the elderly people have done studies quite convincingly, and that statins should be continued. There was a suspicion that if you actually got to your 80s, you didn't have any heart disease and therefore you didn't need a statin because you got there without an event, but that's actually not true. And if you have got fit and healthy people in their 80s who have high lipids, then they should be on statins. And indeed, if you look at the 10-year risk of having an event, by the time you're 70, you don't have to ask them any other questions. They will fulfill the criteria for a statin. And so you should really be starting everybody on the age of 70 who can tolerate it on a statin, and you shouldn't stop it at all. There are some combo tablets that you can use if you need to reduce polypharmacy. But I guess the decision is, if the patients get too confused, then you have to make decisions that are based on risk of the patients taking too many or whatever, rather than based on their risk of cardiovascular events. But there is no doubt the evidence is there that it doesn't matter what age you are in terms of being elderly, you will benefit from a statin.
Thank you, Jill. We've got an interesting question from Panna. Panna Mukit asks, with regards to erectile dysfunction, should you be carrying out ABPIs on male patients who present with erectile dysfunction? That's the first question.
Yeah.
And secondly, should you treat them for primary prevention, assuming they are already high risk?
Yes, I mean, the issue is they should be treated for primary prevention. If you look at all the guidelines nowadays, they don't actually specify a disease. They actually just say at high risk of, and they'll give you a percent of having an event within 5 or 10 years. And that includes peripheral arterial disease, obviously, but also includes erectile dysfunction. Now, the issue is that you can get erectile dysfunction for other causes, for example, diabetes, peripheral neuropathy, but then you are going to be treating your patients with diabetes with a statin in any event. And the vast majority of erectile dysfunction are caused by problems with the vasculature and not with the nervous system. And usually you've got other signs like multiple sclerosis or amyotrophic, etc., etc. So yes, you would treat these patients with a statin. I'm not an expert on how to treat or how to diagnose it, and so I don't know the answer to the first part of your question, so sorry about that. All I know is that when I ask my patients, it makes me very much determined to make sure they're treated to target, because it's an extra risk factor.
Yes, thank you. And I think from the cardiovascular risk service point of view as well, when patients do mention past history of erectile dysfunction or ongoing issues, then we do have a much lower threshold of treating these patients, particularly with statins, and looking out for blood pressure issues as well. So thank you for that question. There's a question here from Jacqueline Walker. There's a very practical question with regards to patients with peripheral arterial disease and foot wounds, and whether you would withhold an SGLT2 inhibitor in these patients when they present.
Yes, that's a really good question. As you know, when you've got a wound and liable to be infected, you require 8 times more blood supply to heal a wound than you do to maintain skin integrity. And so most people will recommend to stop these inhibitors whilst you have an open wound. I have to say, I am, if the patients are well controlled on it and they're sensible patients, I will keep them on it. There was a scare, as you know, some of the anti-diabetic medication was linked to amputation, but the more recent studies have disproven that. And so I tend to leave them on it, but I think that's a judgment on how sensible you think the patient is. I do believe that our patients with peripheral arterial disease should all see a chiropodist regularly. And I'm not sure if that actually happens, because again, as I say, you just need to clip the tip of the toe and you require 8 times more blood supply to heal it. And we often see patients coming in who've been perfectly okay with intermittent claudication tipped into critical limb ischemia because they cut their nails wrongly or their shoes were rubbing and they didn't get that seen to properly. So yeah, that would be my answer. Not 100% convincing, but I don't stop it.
Thank you. And why do you think, Jill, that patients with peripheral arterial disease are much poorly treated, although it's getting better, than patients with coronary artery disease? Is this just not as sexy as probably coronary artery disease in the eyes of a lot of the treating clinicians, or is this not just being thought of as a high risk enough condition?
I think it's multifactorial, in fact, but it really goes high. I don't know, you probably, I'm sure you all remember QOF. I mean, QOF actually rewarded you for managing risk in stroke and cardiac disease, and it didn't reward you for managing it in peripheral arterial disease. And, you know, we went down and had an early morning question, and I measured ABIs and all our MPs, and I can tell you their blood pressure was quite frightening, but there you go. And it really starts from the top. I mean, you know, if you were to say to somebody, do you want a heart attack or do you want pain in your legs when you walk? They're going to say, I want pain in the legs when I walk. And unfortunately, that's sort of rubbed off into medical care. I think it is changing now, but as I say, QOF wasn't that long ago when, you know, GPs were not encouraged to look and treat patients with PAD. But the other reason is, and I don't mean this critically, is that a lot of patients are looked after by surgeons, and surgeons operate, and physicians treat risk. And so it has been a bit of an uphill struggle to get our surgeons involved in statin therapy. And I think sometimes when a patient is discharged from a surgeon, you feel, well, they've dealt with what should be dealt with. And in the olden days, I don't think surgeons did recommend statins. Now, I actually know from getting patients up that my primary care colleagues are excellent at managing risk in peripheral arterial disease. And what I've really done today is highlight the two things that I think are missing. And one is the checking and treating to target and going on to a PCSK9 inhibitor if you don't manage it. And then the second thing is the ACE inhibitor. But apart from that, I think our primary care colleagues are really doing much better. And I hope that these data from Europe are reflected here in Scotland in terms of better management.
Thank you, Jill. I can't see any further questions from the audience. Last chance if anybody wants to ask any further questions. Right, Heather, thanks. She apologized, you missed the start of the presentation. I think you mentioned the difference in men and women. Does peripheral arterial disease present differently in terms of symptoms between men and women?
Yes, part of the reason that it is diagnosed less frequently in women is that they tend more commonly to have atypical presentation. Now, nobody knows why, but they very often will get foot claudication or thigh claudication or buttock. Buttock's very common in women because of the distribution. We don't know why. And of course, they put it down to back. And I think that has contributed to a lot of patients with claudication not being diagnosed. Secondly, historically, in the 70s and possibly the 80s, less women smoked. And of course, we're now seeing people who have smoked since the 70s and 80s. And so again, women tended to smoke less. And I don't know if you saw the slide showing that Black women have the same prevalence of peripheral arterial disease as Black men and white men. And so there's obviously a genetic element, possibly linked to diabetes because it's much more common in Asian women as well. And so it might be linked to the high prevalence of diabetes. But certainly we miss it in women because they present atypically. Women tended in the olden days to smoke less, but remember now that we're a multicultural society, our Black and Asian women are suffering from peripheral arterial disease to the same prevalence as men.